Carol's presentation. What an enormous amount of information to take on board, and great to see the evidence base growing as well. And some reflections that perhaps we're actually starting to get it right. When we put the consensus statement together 4 years ago, we were thrilled with the number of signatories who came on board, representatives from all of the diverse groups who actually need to work together to make this reality. So there's employers, unions, GPs and other health professionals. Did I say unions? Yeah, and the unions. And I'm really pleased just to let you know that over morning coffee we had a photo session with Dame Carol with 3 new signatories to the consensus statement. That was Fonterra, New Zealand's major employer, and their 2 unions, the DWU, the Dairy Workers Union, and the EPMU. So actually, just to plug, we do want to increase the signatory base. We want to increase the movement. So if your organisation are not a signatory and you would like to be, then please let one of the RACP team know that, or myself. Be great to have you on board. So representatives of all of those major groups are here with me on the platform today. So that's the employers, the unions, the GPs, and government. That was the other group I didn't say before. And we have 2 government departments represented here. If I could perhaps just introduce them. From the far end, and of course they're in a different order to my notes. So at the far end we have Mrs. Maury Leyland, who's Director of People, Culture and Strategy for Fonterra. Next to her, we have Dr. Tim Malloy, who is President of the Royal New Zealand College of General Practitioners. Next to him, we have Dr. Geraint Emrys, who's Manager Corporate Clinical Advice for ACC. We then have one of my colleagues in the faculty, you can tell by the tie, and that's Dr. Warren Harricks, who is chair of the Health Benefits of Work Steering Group Executive for the faculty. We then have David Bratt, who's a Principal Medical Advisor for the Ministry of Social Development. And we have, very kindly at the last minute, stepping in for Helen Kelly, we have Bill Newson, who is the National Secretary of the EPMU, also known as the Engineering Printers and Manufacturers Union. And an old friend of ours, Paul Mackay, who, as I say, was on the very first panel 5 years ago. Paul is Manager Employment Relations Policy for Business New Zealand.
On the far left. No appropriate.
Now. As I go around talking to employers or talking to GPs, the employers say, but the GPs never get in touch with us. And I talk to the GPs and they say, but the employers never get in touch with us. And actually, the fact that we've got a sick note means that there is effectively a blocker there and there are no clear lines of communication. So one of the things I'd like to just raise as an issue is, how do we improve communication between employers and GPs? Paul, perhaps you pick that up from an employer's perspective.
Thanks, David. Yes, there's 3 broad aspects to this. The first is what has just been mentioned. There is this kind of barrier, Chinese wall, call it what you will, in the form of the sick note, underpinned by things like client privilege or patient privilege and so on. That's true and it's real. The 2 things I think that really stick out, though, in terms of hearing who we heard Dame Carol say this morning, and the sorts of conversations I hear from employers, and also talking with unions and others, and with PHOs. The first is that employers know that they have a lot of employees. Employers go to a lot of GPs, and a lot of GPs work inside PHOs where there are a lot of GPs inside one PHO. The point is, there that's very difficult to form relationships. And I think the word relationship is one of the critical aspects of this entire conversation. How does an employer form a relationship in which there is a point-to-point conversation going on? Because once you develop the conversation, the criticisms about they never talk to us can fall away. And that brings up the possibility of having some form of liaison connections or customer contact type connections to manage these conversations. I know I have to be extremely brief, so I'll just deal with the second aspect quickly as well. And Dame Carroll, in her presentation, had a diagram that talked about the transition from work to sickness to not being in work and then being on benefits. The transitions from each of those stages, to me, form alarm bells. They're alarms, they're flags. They're not fixated points, they're not points of intervention necessarily as much as the bits in the middle are. While you're in work, preventing the flag coming up for being sick. While you're sick, preventing the flag from coming up that says that you're out of work. There's the areas of interventions, and that's the space in which we can invite people like GPs to work and talk to us as employers without necessarily breaching client confidentiality, because we're not necessarily talking about a sick patient, but talking about the workplace and all of their patients before they come to the GP. So there's two thoughts for you. One is liaison, point customer contacts, and the other was working more in the space that is not the alarm bell, the transition into sickness or into not work or to unemployment, but into the intervening spaces where we can have generic conversations, be beneficial with them.
Bill, I could see you nodding vehemently there. What's that about?
Yeah, well, we were having our own muttering conversation down the back about this these engagement points. Can I just say, I don't speak on behalf of the union movement, I'm stepping in for Helen Kelly, and I wouldn't like to acknowledge the General Secretary of the Dairy Workers Union, Chris Flatt, who's here, for example. But I think I do reflect the general view of unions, which is one of support, obviously, for the general notion of rehabilitation, return to work. The concern that unions have is, if I could not put too fine a point on it, people being beaten back to work with a blunt stick, if you like, and then the support systems, once they're back at work, to make sure it's real rehabilitation. And I don't see why GPs wouldn't have the same concerns.
Yep.
And so I think the opportunity is there, and some of this was coming through from that excellent presentation this morning. And I thought it was great, that reference to good quality work coming through. But I think the opportunity is there in this nexus between employers and the health professionals to really sharpen up what the system's going to be that's going to support that return to work and what that rehabilitation. I don't see why employers shouldn't be obliged to, kind of prove that system is there. In a lot of instances, the injury that's been caused happened in that workplace. So the worker, and I've had personal experience of this, going back into a workplace where you've suffered traumatic injury. So what's actually been done about that? Has it? Is there going to be a proper professional trained case manager supporting not just the worker but the company? Let's face it, a lot of employers are small, ill-resourced, and I think that is a factor. As opposed to the supervisor being the case manager in effect. So what are the support systems? Is there a health and safety committee that can help monitor the return to work regime and the rehabilitation regime? So being able to illustrate that there are concrete, structural, process-orientated elements in place in the workplace that's going to support that return to work, I think would give the worker more confidence, obviously, but would give the GP a greater understanding of where that, let's face it, their patient, that critical trust relationship between the injured party and the GP. Would give that GP more trust and confidence in the environment the worker's going back into.
So it sounds like you're saying that we need some agreed principles for best practice. So that we can measure employers against best practice.
Agreed principles, but also a good support structure in place, and the government's got to play a role there. And I don't see why ACC can't play a bigger role, frankly.
Yep. Okay. Tim, from a GP perspective?
Well, first of all, can I just say it's a pleasure to be one of only 3 GPs here in the room talking about something which is so critical to our day-to-day lives. But can I just answer the question by saying that, in my opinion, certification is the least effective mechanism for good communication, and that realistically we need to find ways to create an environment which, in my view, is a whole of system environment in which we can solve this problem by removal of the barriers. In our day-to-day work, we have 13 different acts of Parliament which control the way we behave. One of the most important is that of the Privacy Act. The Privacy Act overrides, we think or believe, in precedence over all of the other acts under which we are constrained. As a result, the interaction with our patients is controlled by our patients. It seems to me, if we are to address this issue of the interaction between particularly employers and our patients or their employees, then it must be with the permission of the employee. And that perhaps that if the communication issue is of such a concern, and I believe it to be the case, that we should simply suggest, for example, that the employer or the employer representative be invited to the consultation with the GP and the employee. You are thus obtaining informed consent. The conversations are frank. The protection for the employee is there in the third party, namely the general practitioner, and the employer gets an opportunity to understand with clarity around the scenario. I've never had an employer ask me if they can come to the consultation with their employee. Why not?
I have heard examples of that occurring, and I've also heard examples of where there has been a criticism of that approach, in that the line manager has pretty much insisted that he comes along to the consultation. And I think that creates a slight tension, not insurmountable, because I think it's a really good suggestion. But again, we need some principles around that. And I think, Robin, am I right in thinking that in Australia this issue has been tackled rather more robustly?
Yes, I mean, it depends on jurisdictions because it's all fragmented in Australia. But broadly, it's quite common for employer representatives to join in a consultation with the general practitioner, either at a case conference or just at the initial consultation. But it has to be with the approval and agreement on the part of the worker. If they say, no, I don't want to be in, then the employer has no rights to it. But there's a general acceptance that for appropriate rehabilitation, the employer doesn't really
I think we should not lose that expression, case conference, because I think case conferencing can be an incredibly powerful tool to get everyone around the table, including the GP and the line manager and the union representative, indeed. Anybody else? Yeah, Warren.
In the Australian Capital Territory, under legislation, if someone has a work-related injury and it looks as though they're going to be off work for more than 31 days, under legislation, then a rehabilitation case manager is required and will come and talk to the GP and will liaise with the employer or the case manager for the employer.
David.
It seems to me that actually we're missing one of the key points that Dame Carroll made, and we're taking a terribly medicalised approach. The reality is that some of the research work done by Samantha Elwood showed that in fact the medical issue or the disability issue is about 10% of the reason people don't return to work. So if a third of the reason has to do with the employer and a poor working relationship with the employer, then the patient, client, whatever we like to call them, is not actually going to discuss that issue with the employer in front of the GP, in my view. And the other third is a whole range of other issues, catastrophisation, beliefs, etc. Nothing to do with the actual condition. So if we're going to make progress, we've actually got to look at that wider biosocial view and how we get that, and that does involve the much wider community. It sounded terribly medical up to date, which I think will miss the point.
Carol, I can see you scribbling away madly. I know you've got some thoughts on this. What do you think?
No, I mean, it was to try and deal with what David has just said, that when we suggested the Fit for Work service, was to try and deal with these three elements. And I would agree with David entirely that even though the medical certificate says a medical reason, it is probably 80% otherwise. And if you don't deal with the other, it doesn't matter how hard you try to deal with the medical bit. And in the Fit for Work service, if it worked properly, the idea was there would be an appropriate case manager who, with the permission of the employee patient, would then be the bridge to the employer, partly because our general practitioners have made it quite clear to us that they do not want direct contact. And they don't have time, and they don't consider it particularly appropriate. They acknowledge that these problems exist, of course. They would wish we had lots more occupational health professionals who would do it. But in view of the fact we don't, we're really struggling to think, how do we make that communication, which is crucial, work with the sort of personnel that we've got. But so much of it does not require a medical input.
Can I just open the question up to the floor? What do you think? Have you got any examples that you could share of good communication, perhaps, between employers and GPs? Professor Glass.
I think the tricky issue you're touching on there, you try to get an employer and a doctor to communicate, and they speak completely different languages, and they're both extremely busy. Now, one example that I heard spoken about in the UK some years ago was the issue of dealing with mental health. I think it was in one of the Scandinavian countries, where they used a link health worker, a person who could speak the language of the GP and who could speak the language of the employer. And to me, the ideal person in the New Zealand setup is the occupational health nurse. And I think we've got that potential structure here if we'd only use it.
Right, thank you for that. Rumby, there's a question over to the right, and then one towards the back. Sorry, could you use the microphone, please?
Often people with injury is quite straightforward. Often mental health issues are much more difficult to identify the causes particularly, and I feel that I'm in quite a privileged position because I can talk to the employee and identify what the issues are and say, well, look, we'll only disclose what you feel comfortable with, disclosing, but I can also ring the GP or write to them and say, this is what we're proposing, is it okay? And work quite closely with people from that perspective and keep them at work, because often GPs don't understand what is actually available and how we can support individuals to stay there. So I strongly believe that occupational health nurses have quite a strong role to play, because we work closely with HR and work with the employer. We can work with the union groups, whoever has an interest in that particular person's welfare. So I feel quite strongly that we've lost our way in terms of supporting individuals from a psychosocial perspective at work, because we've moved heavily to the safety side, and that psychosocial side is missing.
And we ignore that at our peril, clearly, from what Carol has been telling us about mental health issues. So there's a question at the back here, Rumby. Oh, sorry, no. Oh, yeah, there we go.
I think it's quite important that we actually look at good practice and things that we're actually doing well already in this country. As a service provider doing return to work for injuries with ACC, we already have a great example of people that are going out and liaising between employers, occupational health professionals, GPs and specialists, and we're already actively doing that to help people return to work after an injury. And quite often we know that the barriers to return to work are not actually the injury or the physical things, but the psychosocial flags that we identify. So we've actually got really good examples of practice and us doing that. And maybe what we need to think about is how we transfer that into more of a health area than a specifically injury-related area.
Thank you, Grace. I think you make a really good point, a really important point. I've heard Carl Stent from the Accredited Employers Association talk about this a lot. He points out we're really good. The accredited employers are very good at injury management. ACC is very good at injury management. But actually, injury accounts for about 20% of sickness absence. And many organisations pretty much ignore the 80% of medically related sickness absence, which is going to be largely mental health issues and musculoskeletal issues. So we've got to have a change of focus. Thank you, Jim.
Jim McLeod, I do occupational health in Northland. I work with a lot of occ health nurses as part of my team, and I have to say that as a liaison professional, I think they're experts. And I would absolutely endorse the thinking of others that occupational health nurses, I think, are one of the key link potentials between general practice and workplaces, because they do understand them both. I guess my question is, given that, as you've just pointed out, illness is actually one of the biggest causes of absence rather than injury, because injury tends to be well managed, as we've just had pointed out, where's the funding going to come to actually help that happen? And, you know, I mean, ACC by law is excluded from that particular area. Do employers, does New Zealand Business think that there's actually room for them to start thinking about augmenting this process as we've outlined?
Thank you very much, Jim. And I think that's actually a two-pronged question, because I think we do need to ask that of employers. Would they be prepared to fund this? But it's also a question for Ministry of Social Development in terms of the investment approach to reducing sickness beneficiaries. Maury?
Well, when the discussion first started, it seemed to me to be quite a medical question. But as it's gone on, obviously we're not talking about a medical question at all. And as I hear the discussion, what I hear is that what we're really looking for is employees to be engaged. And when you're engaged, you've got people in your workplace. We do an engagement survey at Fonterra. One of the questions is, do I have a best friend at work? It's a bit of an awkward question for people, but I think that the answer is, if you answer that question yes, and you're struggling with these problems, then you're probably going to find somebody to talk to and connect with somebody. Maybe that leads you through an occupational health nurse to a GP. But to me, that's the real root cause here. It's the engagement of the employee, the way they feel in the workplace. If the line manager is not the person who's able to provide them with the support they need, who do they know to reach out to, or who can they reach out to who can connect them to the right place?
Yeah, thank you. Paul? Oh, yeah.
Yeah, absolutely, employers believe in that. And I spoke of the idea of liaison, and obviously health nurses are an absolutely major piece of that concept. Well, it can be broader as well. The thing is, how do you provide the infrastructure within which that becomes possible? One of the things I did in my recent past is I was one of the members of the Independent Task Force on Health and Safety, which is the progenitor of what we're seeing now with health and safety law. That process recognised that what we dealt with and what's coming through in law is the tip of the iceberg, literally the tip of the iceberg, the 10% above the water, and that what's below the water is occupational. It's health, it's wellness, it's mental, and it's all those other things. What the government has done is acknowledge the enormity of that challenge and promise that it will not be lost or forgotten, but presently we still do not have the basic infrastructure to deal with it in the same way that we deal with safety. We need it not to be the second cousin. It needs to be health and safety, not just safety. So where employers come from is that we will invest in what makes sense, but we need the infrastructure within which to do it, to support it and make it work.
Bill?
Yeah, just endorse that notion of occupational health nurses, or whatever the structure is. If we're going to have a structure, it certainly needs to be much better resourced and trained. But can't argue with the occupational nurse system. we've lost something actually very valuable in what we've lost there, I think. Not just the service, but the actual capacity that was there. Can I just get back to the worker? Because I wouldn't I? But let's face it, it's a worker who's been injured. It's the worker who's ill,
Yes.
whatever the illness is.
Yes, absolutely.
So it's the worker who's vulnerable.
Yep.
And we all argue that part of kind of managing that vulnerable and making that worker well again, you know, and self-esteem is you know, reintegration back into work. But that worker is in a very vulnerable situation, and I can tell you, and you all would have had experience of this, you know, working people, generalisation, but it stacks up, people trust their doctors. That's a really strong relationship of trust. People also are loath, remember, particularly in a vulnerable situation, to get into conflict with their employer. So it's very important that when this process is happening, if it's happening under whichever structure and however resource, very important that that worker has representation as well, and that worker knows their rights. Now, there's an education campaign there, so people should know, I think the comment was made in the presentation about people should know before the accident, you know, what might happen afterwards. But very important that representation is there. Unions can offer representation, but you know, our ability to offer representation is so often undermined by fear and loathing and rejection of the role of unions in society. And so many people aren't in unions, so how do they get that representation? Because until you can actually give that vulnerable person some security to engage, then that vulnerability is going to carry on, because they're not going to speak up, and they're going to end up in situations where they're back in the workplace and the real rehab's not happening. Whether it's physical health or mental health, what was the expression? They're on the wheel, the spinning wheel, the hamster wheel.
Can I just say, Bill, I've got this kind of automatic reaction to the word rights, which is the converse responsibilities. And the other thing that we need to be clear about workers is that they also have a responsibility to take control of their own outcome and their own destiny. And what we should be thinking of is actually how we support workers to achieve that.
Yeah, sure.
Just segueing on from this, raises the question, just how hard would it be to introduce the fit note in New Zealand compared to the sick note we've got now? Bearing in mind that we can design it as we want to design it. It does not have to be the same as the UK model. Can I put that one to you, Tim?
Currently we have 3 siloed systems. One's the ACC, one is the MSD, and one is the Medical Certificate of Employed People. There would need to be a standardisation across that process. It would need to be electronic to fit into our systems. It would have to be the same in all 3 silos, which means government departments would actually have to talk to one another and work together, which would be quite some novel thing, instead of talking about it. And we'd also have to have a significant component of training and retraining and change management within the sector as a whole.
Thank you, Tim. One of the things that we've missed so far is the fact that ACC have been on this journey with us from the start also, and great to have Kevin Morris here today. Kevin Morris was the Chief Medical Advisor to ACC 5 years ago when we launched the project, the Health Benefits of Work project. And Kevin was instrumental in ACC taking up the fit note capacity for work concept from the outset. So actually, ACC are leaps and bounds ahead of the game here. So I'm going to ask Geraint just to comment on that.
Well, the history, starting from Kevin's work, has been that we have piloted and trialled work about projects about keeping people in work and working with GPs. And those were some of the most closely evaluated projects that ACC has done. And they've shown mixed results about efficacy. And I think this is some of the issue around data, is can we really show how things work? Nevertheless, we've pushed on and we've rolled out different services. and we can report that we're getting very mixed usage of those services, which in fact are liaison services to enable communication between GP, employer and employee. And we've also rolled out, as you've heard, an electronic fit note in some form, a capacity where there is the opportunity to state how long somebody should be signed off as fully unfit, or if they're fit for selected work, what that might look like. But again, there's been some limited uptake of the use of some of that mechanism that's available. So I think there is an issue around the capability of the sector to engage with that and to understand that work is an integral part of the service that's been provided to the individual that it's going to assist their recovery, and at the end of the day is really essential so that the GP or the specialist interaction does not in itself lead to further harm. And I think that's some of the data here that we are hearing, that people have got very fixed beliefs which may or may not be accurate about whether they're safe in work, whether they have a capacity or not. And somebody has got to have the capability to work through all of those competing issues. And I think that the note is a mechanism that perhaps can enable some of that.
Yeah. And I'm aware that ACC are introducing a new contract in July this year for vocational medical services, which involves the likes of occupational physicians like myself. And this is specifically aimed at the more complex end of the cases, whereby we will see and assess the individual, we will identify the issues, and then we will communicate with the GP and with the rehabilitation providers who are actually helping them to return to work. So we've also got a very active role as an intermediary. Our role we see as a facilitator of the process, as a bridge between the workplace and the health system. Something that we have embraced as a concept from ACC. So I think it's a real step forward there. There's a question right at the back there. Rumby, close to you.
Yes, I have just a bit of a comment. I'm Carolyn Habertle. I'm also an occupational health advisor. When do we start working on breaking down the infrastructures? So the OC physicians and the OC health nurses, they work really well together, but usually that's when the person has already way down the track and there's a problem. ACC are doing some really great work in their return to work, but they're working in their silo with GPs. GPs are working in their silos, they've got their private business, and that's what they're aiming to keep their business alive. But when do we break the structure down and start looking at how we holistically look at this as a better picture in New Zealand instead of working in silos?
I think that's a really good point. We've got clear definition of individual roles. Where's the integration? Yes, Paul.
There's a couple of thoughts come out of those last remarks. The whole issue of getting better use is as much culture as it is systemic, and we certainly recognise the mechanical issues about bringing current systems together, producing a fit for work note that is commonly used. But that too is almost the tip of the iceberg, because underpinning that is building with common knowledge of what's possible given that I'm going to give this note. Not every GP is knowledgeable about every aspect of every occupation, or in fact no GP is knowledgeable about every aspect of every occupation, and yet ultimately what we need to build towards is the ability for the GP or the practicing physician to say, given your circumstances, given what you've told me that you do, and given what I know of what you do, we can look at these different options. And they need not be the only option. It need not be light work for the electrician or writing manuals for the electrician who can't climb a ladder. If you look at, for instance, in the police or the armed services, they've taken some of this concept to say, given that you're not able to do what you were employed initially to do, can we use this opportunity to retrain you and therefore multi-skill you for the future? And then you're actually more valuable to us in the future, rather than just making you available for work, reintegrating you at least with your collegial relationships and things. Let's look for value add here in terms of the longer term. There's opportunities there too, but that can only come from a reasonably broad-based commonly sourced understanding of what's possible. And so in taking the mechanics of developing the footnote and developing it, so too I think we need to develop the common resource about what that means and what's possible when you issue one.
Fantastic. Question down here.
Principal Disability Advisor at the Ministry of Social Development. I found it interesting that we've moved away from some of the primary discussion into a particular area around injury. And one of the things that we identified was the 80%. One of the things I heard, particularly in Dame Carol's work, was around early intervention, which happens in the workplace, and adaptation, which Paul was starting to talk about. We've moved away from that and started to really think about how we, again, medicalise it. How do we actually, often mental health is first identified in the workplace. How do we actually empower the workplace to effectively get the best out of the employees they have working for them, and how do we empower line managers? One of the examples used was mindful employers, and a range of other tools that I think we've moved away from.
That's a really good question, Anne, and clearly Dame Carol touched on those issues in her talk. I know we have a number of people in the audience who have expertise in mental health in the workplace. That's a prime for Helen Lockett to say, what do you, I'm not sure where Helen is now. Where are you, Helen? Oh, she is? She is, she's hiding away. Okay. So I know that, so Helen is the policy officer for the policy advisor for the WISE Group, New Zealand's largest mental health charity, and they've put a lot of work into providing supportive workplaces and working with employers to build their capacity for helping support people with mental health conditions in the workplace, and that's mental health conditions all across the spectrum. But you're absolutely right, we've got to put those initiatives in place. So mental health is one aspect that clearly is a major that we must tackle, and something that the UK is now starting to focus on, which is really helpful to know. And I know that Paul Litfield came out last year and spoke to us about his experience in BT and the emphasis that British Telecom have had on mental health in their workers, as Carol alluded to. But we've got another problem out there, another growing problem, which Carol also alluded to, and that's the epidemic, near pandemic in the developed world, of obesity, diabetes, cardiovascular disease. Have we got the opportunity to influence those conditions in the workplace? Greg.
Hi. Just recently joined Fonterra and speaking with my Australian experience, I think what Maury alluded to before around engaging our employees is one area that would attempt to tackle this issue. If we engage our employees to get them in a safer place, and that is a place where they can communicate freely with us as employers, then we've got half a chance to impact the outcome of that person wanting to be rehabilitated back into the workplace, as opposed to getting on that hamster wheel of where are my options, how do I cope with the pressures of work, how do I cope with all of the difficulties in being able to navigate through. So from my perspective and my experiences in this space, there is a really big piece, and I really like the wellbeing framework that's been discussed really all morning and all through this discussion, which is around understanding what wellbeing means to our employees and then tackling those issues so that if they are injured or if they are affected by the stresses of life that need a support base, that we can identify those early. And talking about intervention, we can intervene early if we know, and those employees need to feel safe. Coming back to what Bill was saying, employees do need a support, do need representation, do need help. And if they do injured, it's our responsibility to help them. So this whole factor of care, this whole factor of how we engage our employees and how we get programs in place is a pivotal point. And I think certainly in Australia's context, we've woken up in Australia that this costs a lot of money to deal with the aftermath. So invest the money up front, invest it in your business, invest it in the people who can bring that experience and identification of these areas. And certainly it does have a good commercial outcome as well as the good moral thing to do as an employer.
Thank you. I know we've only got a small number of GPs here today, but we've also got some representatives from GPs groups. Roger, I hope you realised that I was suggesting that you might say something at this point. How do you see the role of the GP going forward? Rumby's coming over with a mic. He didn't know I was going to do that, by the way.
Roger Bowie. I'm representing Green Cross Health Medical. We've got somewhere over 250 GPs in our network. I wasn't going to answer that question.
That's fine.
Because I think Tim has already answered it, and I would make the observation that in the time that I've been directly involved in investing in primary care, which is now six or 7 years, I think we have seen a shift in appreciation of the health benefits of work in our GP workforce.
Great.
I don't think that's the issue, and I think a lot of the other people have indirectly pointed to probably the main issue here, and that is what is the barrier to the integration of all of the goodwill and all of the good ideas that we're hearing from the individuals in the panel and from the floor. I also have experience as a funder of healthcare, passive funder of healthcare. And the lesson I learned from that is that health systems typically behave the way they are paid. So it's not just about the money, but it is about the money. And I've always, you've heard me several times argue the point that the single biggest new dynamic that we could introduce into our health system to support a change in incentives which would unstick the system that we all feel stuck by is the emergence of the employer as an astute purchaser of healthcare. Just as the ACC regime has supported the emergence of the employer as an astute purchaser / manager of safety risk. How do we get the employer into the dynamic? How do we get the employer to almost buy their way into that conversation that Tim's arguing we should have around the benefits of work with the patient? How do we do that? And I was very interested to hear of the experience from the UK with two things that really struck me in Dame Carroll's presentation, amongst a lot of other things. But two things were that they were actually identifying the economic value, right, of presenteeism and absenteeism. And I know there's a lot of data out of the US, but the US system is so much different.
Yeah.
It would seem to me there's a lot more relevance from the UK system. So I'd like to know how those health benefits can be translated into turning on the risk manager within an employer, because I'm also an employer. How does my CFO understand the benefit of the investment in buying time from the GP to spend time with my health and safety person or my occupational health person? That's the first point. And the second point, I thought I saw, I may be wrong on this, that there has been the introduction of tax incentives for the spending of the health dollar in that way. So I've made a few points, but my real question is there anything from the UK experience that we can pick up that supports the transformation of the employer into an astute purchaser of healthcare?
Great question, Roger. I think that's one for Carol.
Thank you. I mean, what we've been really trying to do, I think, in the UK is show the employers, whether they're large or small, that they investing in the health and well-being of their employees meets either their bottom line financially, so that it is an investment that will return on the pounds, or it will have a return in the, if you like, the engagement of the employee to the company. And the biggest barrier I have seen is really trying to get usually the finance director of the company to actually take this on. But when you talk to people like Paul Litfield and ask Paul, well, what made the board of BT do all the things they've done, he said, in fact, they didn't do it on a business case, which is interesting. They did it because, one, they thought they should do it, and two, it was going to give them more engagement and a much weller a group of employees. One of the things that I really felt we should have considered at home, which isn't quite in the employer area, but I do think we could have incentivized our GPs more appropriately to be much bigger players in this. And I do by that mean financial incentivization. I think that would have brought them to the table much more than they're busy. They are small businesses, and at home they're absolutely small businesses. And it always seemed to me that there's been one half of the equation where we haven't actually made it the easiest we could for ourselves in terms for who puts money where. And if the government was going to put money in, I think it's beginning to give the employer tax relief, which was welcomed by the employers. And if they probably need, if that's successful, to think about doing more in that space. So the employer is then buying more of rehabilitation services, which is what they said they would do if they got some tax relief. I think, on the other hand, we haven't given our GPs any incentive for them to come to the table in an appropriate way, and that would sort of start to bring some of the silos in alignment. So I think we need to think a lot further about how we start to get our incentives the right way if we really want the system to motor faster than we've got it at the moment.
Thank you, Carol. We've heard that GPs are running a business. We've heard that they're very busy. We've heard that there are demands on their time. We've heard that they need, we need to recognise that, and there needs to be financial compensation for time spent working with employers. Maury, would Fonterra be interested in being an astute investor in healthcare?
Yeah, I think I have to answer that question in a way which goes back to, probably has to tell a bigger story about Fonterra, because we've had quite a bumpy journey the last few years. We've been through a few difficult situations where we've had to do a lot of reflecting on ourselves and what we stand for, and our role in society and with our people. And I guess coming out of that, we've got to the point where our purpose, if you like, is to be the world's most trusted source of dairy nutrition. So there's two things about people in there. One is nutrition, because that's about health, and our role is to provide healthy nutrition in the world, and we're touching over 1 billion people around the world. The second part is the trust, and while trust is a big word, trust comes from people's relationships with people. And so to do that, we have to have a business strategy, which is where your business cases come from, and I think you'd struggle to ever get one to get down to the level of detail which supports some GP investment. But it also comes with our reputation, and our reputation again is reflected by people and the way that we operate. And the whole thing is driven by the engagement of our people, and it really takes as much priority as the other two do, so our business performance and our broader reputation in society. So for us, measured by the board, we have a People, Culture and Safety Committee. Some of the most prominent members of our board are represented there, and their drive around the need for strong engagement and the benefits that flow from that, the many benefits that flow from that across all of those things, and the wellness of our employees, obviously an absolutely critical driver of that is key. And Their voice is very loud, it's very clear, and the CFO absolutely understands that. So I guess if I was to come with a case that for us to make that difference, this was an investment that was needed, I would absolutely be listened to.
Great. Thank you, Maury. That's really encouraging. Now, before, I noticed there are a number of hands shot up, but before we do that, I think it's important that we look to Australia and see what initiatives are going on in Australia. Warren, do you just want to say a few words about that?
Yeah, right. Thanks, David. I've spent most of my life trying to stop epidemics. I now want to start one, and that's what we're trying to do in Australia. I mean, we're really preaching to the converted here. But as we heard this morning, we've realised in Australia from the papers that have come out that job control is quite important and the health benefits of good work. Some people are better off not being in a bad job. The mental health is actually worse in a bad job than it is not being at work. So it's important that people are in good work. But I said, we're preaching to the converted here, but we need to get that culture change right through our countries. We need to get it through the general population. We need to get it through all employers, all unions, all government departments, and in the medical profession as well. So we've worked on that. One of the large private companies in Australia in August last year got up and said, health benefits of work needs to be accepted in Australia and New Zealand the same way as wearing seatbelts and immunisation is. And I thought that was a very good analogy. So we're working on that. What we've done is we've created 2 steering groups. We have now 100 signatories to the College's consensus statement in Australia, and we formed a signatory steering group that Suzanne Jones runs. And the college has one representative on that. But there's about 14 people on that committee, and they represent the unions, the employers, the insurers, the reinsurers, government departments, unions, and we also have GP as an important member, as a standing member, compulsory member, to make sure that the employers and things don't put in place initiatives that cannot be managed in general practice. And that group is very active under Suzanne's control the last few months, and they've come up with about 8 initiatives that Suzanne can talk about to some of you that maybe this afternoon. And their job basically is, because what we've seen in Australia, we have different jurisdictions. A lot of the workers' compensations are state-based. Many of our insurers and companies are national-wise, but we're getting some differences in how health benefits of work is being implemented. We have different certificates of capacity being introduced that are different in Western Australia, ACT and Victoria. So what we've done is we brought this stakeholder group together to start to share the experiences, come up with common initiatives, and to drive that culture change about what can be done and what employers can do and what insurers can do, and hopefully get some consensus about that. Also to exchange data. One of the initiatives is to look about how we might actually collect data to be able to share that and actually demonstrate some changes. How can we put together a business case, a financial business case? So that's one very good initiative, and that's really outstanding. One of the things that came out from one of the meetings is, that's all very well, this is what we're doing, but what are you doing about the health, about the doctors? Because they're still writing the certificates. And GPs are in a difficult situation, as we know. They're time poor, and sometimes the medical certificate's the last thing that happens to consultation. And GPs don't get training in that. Most of the surveys indicated that they learn on the job, and some are really quite active and very responsible, and others will just give what the patient wants. So we need to address that issue. So our second steering group is a health steering group, and we're working now with the College of General Practitioners in Australia and our Australian New Zealand Society of Occupational Medicine as the main stakeholders. And we've already had preliminary meetings with them. And we're going to then have a meeting now with hopefully the College of Psychiatrists and also the orthopaedic surgeons. And what we hope to do then is to come up with a strategy about how we're going to educate the health professions, including allied health in Australia. Make them aware of the health benefits of good work. Make them aware that writing a certificate for somebody for more than 30 days is likely to be doing them harm. Teach them about how else you can interact. So we're trying to get those 2 epidemics of culture change both into the industry and into the health profession at the same time.
Right, thank you, Warren. Kevin, I noticed your hand up earlier. Do you want to say something?
Kevin Slee, occupational physician in Melbourne, with WorkSafe Victoria for half the week at least. I just wanted to pick up on a couple of comments that were made earlier about remuneration for GPs.
Yeah.
In Australia, the average GP consultation time is about the same as I saw as it was here in New Zealand, about 6 or 7 minutes. And it's very difficult to actually get through the whole of a consultation and write a certificate in that time. In Victoria, we've recently introduced a new certificate based on health benefits of work, health benefits of safe work, we call it in Victoria. But what I really wanted to say was that WorkSafe have also recognised that the time taken to do the work that's required to do this consultation properly is not going to happen in 6 minutes. So they've invited Deloitte to come in and do an independent review of remuneration for medical services within WorkSafe Victoria, and that report is due in the next month or two. The thrust of that report is to drive behaviours. So we're going to be using carrots to encourage GPs to do the right things when they're actually involved with a workers' compensation consultation. So we'll wait and see what happens. I don't know what the results of that are yet, but watch this space.
Great. So this is part of breaking down the barriers. Yolanda, there's a hand just shot up there and then one behind you.
Good morning, everyone. My name's Karen Everson. I work at the Ministry of Health, and I guess one of the things that is an interesting construct to think about in this frame is the concept of integration, and my area is in long-term chronic conditions, and I guess Tim can probably talk a bit to this around how we don't end up with 10 or 15 cars up the driveway, because many of these people will be also people that are on chronic care management programs or other constructs that we've developed to support people functioning well. And self-management and building patient co-design of their health services is also an important construct of how they manage their wellness outside of the health system. So I guess it's interesting to sort of see this being very medicalised, very GP-centric, when it's a team approach, and Tim's been quite instrumental in building some of that, and would be interested to hear your views on how this could potentially be a negative incentive in some ways of reducing that integration across a person's well-being, and how we might have an unintended consequence of driving behaviour that's not necessarily in the best interests of patient whānau health.
Tim, do you want to pick that one up?
Oh, I couldn't agree with you more. Here we have one agenda to drive integration across the primary care team, and we have the potential to disintegrate it further with some of this conversation. The reality is this is just a small part of the whole of the total patient journey, the total patient care. And don't forget, the employment-related components may be a component of their mental health, but they're never just the only thing. So unless we see this as a whole of system approach to care and include better at work approach within the context of that integrated system, then it's just going to be another good idea. The reality is that funding drives behaviour. And until we actually find a way to get away from more and more siloed funding, more and more targeted incentives, and actually drive a system which is funded to provide an outcome, then we're going to continue to get disintegration. I can't do what I do without my primary care team of nurses, OTs, health psychologists, etc. in my general practice. What I actually want to do is see that expanded. I'm really intrigued with a trial being undertaken here in Wellington by the WISE group, which have actually placed an employment facilitator inside a general practice. And to me, that's starting to get really clever, where it's actually looking at employment per se, not ACC, not work and income, not a person off work from a particular employer, but employment per se, right at the source, where the problem begins at the first presentation. Once we start looking at those kind of integrated models and whole of system, and see it in the context of their health and all their comorbidities. We're actually talking about true generalism.
Thank you, Tim. That all sounded remarkably sensible, I have to say. I think you said, I'm going to come back to you, Carol. I think you said that funding drives behaviour. We need a whole of system approach which is driven by outcomes. And I don't think we can argue with that. I think those are great points.
I've got all the cliches.
Sorry?
I've got all the cliches.
No, I think you captured it. Carol, what do you think?
Just to support really what Tim has said there are parts of the UK where the access to psychological therapy is linked to employment advisors. It's placed within primary care and often within a GP setting. And they have been by far the most successful experiments, because in some areas we've just got access to psychological therapy but without any link up to outcomes as far as employment's concerned. But when you actually start to put things together which matter, so you put general practice, employment advice and support for mental health, it actually does start to drive things in the right direction.
That's great. Thank you, Carol. I know there's a lot of hands up, and I suspect we could probably keep going, but I'm afraid I must draw the meeting to a close, and I think it was fitting that Carol had the last word there. I'm now meant to give a 10-minute summation, which I'm not going to do. What I am going to do is to say that from the perspective of the Royal Australasian College of Physicians and our Faculty of Occupational Environmental Medicine, our intention is to continue to drive the health benefits of good work as being a catalyst for this discussion. We've heard a lot of principles that we need to address. We're going to continue to work very closely with the respective stakeholders to look at whether we need to establish a steering group here in New Zealand, as they have done in Australia. We're going to continue to push the debate on should we be introducing a fit note into New Zealand. And we're going to continue to look at initiatives to improve communication between GPs and employers. What's become absolutely clear from our discussions is that key to all of this is going to be integration, to break down the silos and look at what we need to do to break down those silos. So I'd like to thank the panel for their engagement. It's been really interesting, and the audience also for being interactive here. Dame Carol, once again, thank you so much for coming out, specifically for this event. We really appreciate your input, and I'll be in touch. I'd just like to finish with a few words about our key event partner, and I'm going to ask Bernadine Gordon from AMP to close the meeting for us. So AMP is the leading independent wealth management company in New Zealand and Australia. And AMP help people and organisations build financial security and have been doing so since 1849. Today, they're helping more than 4 million retail customers in New Zealand and Australia own their tomorrow, and business clients across Asia, Europe, the Middle East, and North America. Bernadine.
Thank you, David. Well, hello everyone. I'm Bernadine Gordon, and my role is Director of Underwriting and Claims at AMP in Australia. AMP is very proud to be the premier event partner of today's event, and I'd like to start by specifically acknowledging the guest of honour, Dame Carol Black, of course Dr. David Beaumont, the President of the Faculty, and also every single panel member for such an insightful session today. AMP became a signatory of the Health Benefits of Work Consensus Statement only last year, and I can tell you that we take the role of being a signatory very seriously. Albeit in the infancy, we commenced a very large change program last year to transform the role that we play in the lives of our customers and our people as well. And at the very heart of this transformation is the role that work and health and wellbeing play in helping people to live the best life that they can. Of course, we heard from the panel today that challenges are broad and deep, and as a result, actioning these are also very challenging. As a large insurance company, insights from today certainly resonate with the challenges that we face in supporting ill and injured people to get back to work. And for me, a specific reflection is on the importance of collaboration and partnership, in particular working with all stakeholders, and in particular taking a very holistic view in ensuring the best and the right outcome for every individual. Secondly, we need to be thinking more about recovery at work rather than return to work, and this is certainly an area that we certainly don't have all the answers, but it was very promising to hear that comment made today. As an employer of nearly 6,000 people across Australia and New Zealand, we certainly know that change needs to start from within. And we heard how critical workplace culture and workplace practices are in creating a very engaged and productive workforce. And that is where people feel that they're valued and that they definitely have purpose in showing up to work every day. Lastly, as a senior leader in the life insurance industry, I certainly take my role as well very seriously, and I would actually call out that in my 20-odd years career that I have, this Health Benefits of Work consensus statement has certainly helped to change my views on the role that we play, AMP plays in particular, in helping people to live their best life. And I certainly take very seriously being an advocate of the health benefits of work. So I thank everyone here for your passion and your conviction on this topic, this challenging topic, and on behalf of AMP, thank you.
Thank you, Bernadine, and thank you to AMP for supporting us in this important event along the journey. I look forward to sharing that journey with you further as we go forward. And again, we'd just like to thank the panel members, and particularly Dame Carol, for a really interesting morning. Thank you very much, everybody, for coming. See you next time. Thank you.